مساء الخير. النهارده المحاضرة بتاعتي عن endometrium في IVF patient. طبعا أنا الأول أحب أشكر الدكتور وليد حامد والدكتور مغربي إن أنا allow me to be with you today يعني. And this has been a topic, interesting topic, especially we are freezing more and more embryos than we ever done before. So this is where I've been here for the last 20 years at the University of Miami, Florida. This is our main campus. And I've been in charge of the IVF program, again, for more than 20 years. Our lab is in one of the buildings back there. So what is endometrium? So endometrial sickness is directly correlated to increase in circulating estrogen, and sometimes can be a predictor of success in the ART cycles. There is no consensus on endometrial preparation for FET, whether medicated cycle or natural cycle or what medication use and so on and so forth. Although we always come back to what is the thickness of the endometrium and how it looks before we start adding progesterone for FETs. And some of us use endometrium either below 7 millimeter or below 8 millimeter. It depends on what you read. Although majority of us agree on a fresh cycle, we usually use an 8 millimeter, and a frozen cycle, we use a 7 millimeter as a cut limit for that. The incidence of endometrium in IVF cycle is between 1 to 2.5%, and most likely as high as 10% in a frozen embryo transfer. So this is endometrium. As you can tell, we try to get a sagittal lining, sagittal look, and we try to measure the thickest part of the endometrium just underneath the fundus, near to the fundus of the uterus. And that, again, there's a lot of different reasons the endometrium thickness measurement might be difficult, but that's usually the optimal way to measure the endometrial thickness in our cases. So in 10% of the patients, sometimes very difficult. And the reason for that, if you have a fibroid, where is the fibroid located that can shadow the endometrium? Adenomyosis or the orientation, like, a retroverted uterus, or patient had a previous cesarean section where the uterus is a little bit higher than what you can look in the probe, or the patient overweight or previous. So a lot of ultrasound quality, and not only that, you can have two people measuring endometrium and have a different measurement. So inter-observer and inter-observer variability can happen. And remember, we talk about 6 millimeter, 7 millimeter, or 7 millimeter to 8. It's 1 millimeter. So just keep that in mind. We use a very tiny, try to detect a very tiny thickness in endometrium to say whether one is receptible or not. So the problem is you have when you see endometrium like that, on the left is good, as if everything is great, and you get the endometrium to the right, and then like 3-4 millimeter, and you're really stuck trying to figure how to make that a little bit thicker than this. And that has been a challenge forever in IVT. So those are some of the histories that can point or help us understand why the endometrium is thin. Of course, history of uterine surgery, like if you have myomectomy or the aggressive DNC, where you create the Asherman syndrome. That's one of the most common. Endometritis could be patient with elevated androgen, right? So androgen is anti-estrogen. So patient with elevated androgen would tend to have a thin endometrium. Of hydrosalpinx, the fluid in the fallopian tubes that can go back in the endometrium and create unfavorable conditions or affect the growth of the endometrium. Of course, we have radiations. Smoking mainly is a problem. Septic abortion, it's not the septic abortion itself, but the scarring that can create, and so on and so forth. And sometimes that's, you have to understand, sometimes it's a variation in biology, right? So I always say some of us are 5 feet tall and like 150 centimeters tall, and others are like 2 meters tall, and both of us are normal, right? So there's a big variability in biology that we can account for. So this is one of the earliest study that came from England, and you can see one of the authors here is Dr. Yaqub Khalaf, one of ours, and he looked into endometrium sickness and report in how many patients each of those in each group. Again, to publish 2008 and look at frozen embryo transfer. So that's really, when this study was designed, was just very ahead of its time. And you can look 96 patients, 7 millimeter, 261 patients in 8 millimeter thickness. So out of the 635 patients he have, approximately half of them between 7 to 8 millimeters on those frozen embryo transverse section. And if you look at their pregnancy rate, it divides the patient in two groups. One group is that's 7 to 8 millimeter, and the other group 9 to 14 millimeter. And you can see on this group in the comparison, patients who had between 9 to 14 millimeter have a higher implantation rate, have a higher clinical pregnancy rate, and ongoing pregnancy occurs. And what I like about this is like real number. I mean, like, the 30% pregnancy rate, it's not like 90%, like it's a real number. And you can tell this study is very well designed, very well done, and shows a difference in pregnancy rate in a thinner endometrium versus a thicker endometrium. And I think this is one of the early studies that said that parameters that endometrium thickness is very important for pregnancy and implantation rate in frozen embryo transfer cycle. And he said in that conclusion, in medicated frozen embryo transfer cycle, endometrial thickness between 9 to 14, measured on the day of progesterone supplementation associated with our implantation pregnancy rate compared to endometrial thickness 7 to 8 millimeter. After this study came another study published from Netherlands in 2014. And in this study, actually, they did a systemic review and meta-analysis for IVF cycle. This was not a frozen embryo transfer cycle. It's a fresh IVF cycle. And in this study, they have the patient either below 7 millimeter or above 7 millimeter in thickness. And the good thing about this study, they divide the patient into studies that they polled into the group. One of them is a prospective studies, and the second one is a retrospective studies. If you see the prospective trial, the pregnancy rate, actually, the confidence interval is 0.03 to 1.53. It basically crossed one. So by statistical analysis, there's two studies were statistically not significant in the patient below the 7 millimeter, above 7 millimeter as pregnancy rate in IVF. Now, when he added the retrospective trial was a higher number and showed a statistical significance between the two groups. And of course, when you add the prospective and retrospective, it showed if the endometrium below 7 millimeter, you have a lower pregnancy rate. Again, we always use the prospective trial as the standard of care, right? And the fact that you couldn't show that and could be because of the number and so on and so forth. And what's the conclusion as a result of this? That the current data indicate endometrial thickness has a limited capacity to identify women who have a lower chance to conceive after IVF. So basically, yes, it has could be a lower probability, but those patients can also get pregnant. So it alone, endometrial thickness, the conclusion study might not be a good indicator for success in IVF. So as a result of this, there have been so many studies trying to figure what is the best way to really overcome this thin endometrium. And you see there's a long list of options. I'm going to go over some of them, to discuss whether any of those would help or not. The first one is a prolonged use of estrogen use, right? Sorry for the typo, prolonged estrogen use. And this is one of the earliest studies that, looked into extended use of estrogen. And so in this patient, patient underwent fresh embryo transfer. There have 13 patients was canceled because endometrium was thin. And in subsequent cycles, he put them an extended use of estrogen supplementation. And you can tell in this study, the endometrium went from 6.7 millimeter to 8.6 millimeter on some, but also was extended use, like 14 to 20 to 82 days, up to 82. That's a little bit aggressive when you put somebody in estrogen for 82 days, but it showed that the endometrium will get thicker and showed a better pregnancy rate on those patients. Then we have this study that came, looked into extended use of estrogen in a big number of patients. This is published in April of this year. Looked at 2,026 patients frozen plus cis transfer. And those patients, again, they needed a longer time to get exposed to estrogen to get a thick endometrium, right? And they divided this patient in three groups. A group A was 11 to 14 days, and group B was 15 to 18 days, and group 3 was more than 19 days. And what they found conclude there was no difference in pregnancy rate between the three groups. So whether you expose the patient to estrogen for for 11 days up to 18, 19 days, the pregnancy rate was not different. And those patients also achieved a certain thickness of the endometrium that allows the pregnancy rate and implantation to happen. So this has been one of the good studies that shows that a longer exposure to estrogen does not impact the pregnancy rate and also can increase the pregnancy in this group of patients. Then this is the Viagra or the sildenafil has been one of those thought about, used, tried to figure out whether there's a place for that or not. And this is actually a report that the first time, that's 2000, from the SHARE group in Las Vegas, when they have 4 patients that has a very thin endometrium and decide to use the Viagra or sildenafil citrate, which is a phosphodiesterase 5 inhibitor, which is basically enhance the vasodilator effect of nitric oxide. So it allows more of the blood supply to go to the endometrium. That's the idea behind using Viagra. And they reported on this patient, all the patients achieve a thicker endometrium and the endometrium become more, have a better pregnancy rate. Again, this was a 4-patient report. And after that, there's so many studies tried to reproduce this, some of successful, not. This is a study that looked at the same thing, but they have a more bigger group of patients. And this is from New Jersey. And patient who did not get to 8 millimeter, in the subsequent cycle, they divide them into 2 groups, either gives them increasing dose of estrogen or increasing dose of estrogen and Viagra together. And in the result, none of this really increased the endometrium, and there was no pregnancy rate difference. And subsequently, they say like basically using Viagra in this group of patient will not improve endometrial thickness or pregnancy rate. And this basically topics just put aside for a long time, till like approximately 2015 or 16, was Dr. Mohammed Eid of my university, Cairo University, had this ISRM abstract. And what was interesting about this, it not only they have 22 patients, they measure the uterine artery pulsatility index, basically, which is a measurement of the resistance in the blood vessels. And if you have elevated pulsatility, meaning you have a lower blood supply going to the endometrium. So they have this patient and they put the patient half group on Viagra and other one was no Viagra. And again, they found a higher pregnancy rate and implantation rate in the Viagra group compared to the group not use Viagra. So there's a lot of formations and really all this the data about a small group of patients and it depends what you feel about this. There's not really strong data to suggest that will be of a significant, but again, in any study, when you have a very selective group of patients that use a certain treatment, the outcome will be different than use a bigger group of patients. Then came the low dose of aspirin. I mean, this is aspirin this study was done for oocyte donation recipient with thin endometrium. So this patient, we're going to use a donor oocyte, the endometrium is thin on the initial thing. So they divide, you have 28 patients of those, divide them in 2 groups. One that received aspirin in subsequent cycle and the other one did not receive aspirin, and looked into the pregnancy outcome on this group. And this is very interesting. One of the interesting study about this. The endometrium itself did not get thicker on the aspirin group. There were no increase in endometrium thickness in the aspirin group. However, this patient and the aspirin has a higher implantation rate. It's 24% versus 9%. And the conclusion was a low dose aspirin therapy improved implantation rate in oocyte donation recipient with thin endometrium. Again, did not increase endometrium thickness. It just makes the implantation rate is higher on this group. And I think this is one of the earlier studies that again talked about using aspirin and in the IVF patient that has a thin endometrium. This is one of the prospective randomized trial. It looked into the aspirin. They have 236 patients with endometrium was below 8 millimeter, and they randomized them. 114 patients received aspirin and 122 no aspirin. And they looked at those patients' prospective trial. Very well designed trial. And what I want like you to see here, again, if you look at the endometrial thickness on this cycle, It is a little bit thicker in aspirin, 7.2 versus 5.8. However, there's no significantly difference between group. What was different in the two group is the trilaminar pattern. So it was 46 versus 26%. And the pregnancy rate again was higher in the aspirin group versus the non-aspirin group. Again, this is a second study or like a bigger study that showed more or less the same, although the endometrium was not thicker, and those patients that started still endometrium, it seems to improve pregnancy rate and the endometrium looks better. Then we move to the more controversial stuff. I mean, the granulocyte chronically stimulating factor is a GCSF. It's a very controversial majority of us. Some people agree, some people don't agree, but it is basically it's basically a growth factor that has a positive effect in non-hemolytic cell like endometrium. And the first study, 2011, Glitcher has 4 patients with a thin endometrium between 3 to 6.5 millimeter, and they use the CSF infusion, intrauterine infusion, and it had endometrium increase within 7 millimeter within 48 hours. And again, all the patients got pregnant and one had ectopic pregnancy. And I think that was one of the earlier studies that make us think about whether using CSF it could be of any significance. After that, there is subsequent studies looked into. Subsequent study can see the effect, and as you can tell, there's all conflicting. The retrospective trial, there's no different in LAVE 2014, and another one, Barrett 2014, showed the patient who uses CSF have a higher pregnancy rate. However, this study was done all patients undergoing IVF. It's not at an endometrium at all. Again, 2015 cohort studies, intrauterine infusion, and there's no difference in pregnancy or live birth rate. And that's really put this study a little bit to rest, like using the CSF for a little bit. This is, again, one of the meta-analysis like looked onto the 3 or 4 clinical trial that they select to include this. And again, you can see its favor, the use for thin endometrium, and for trial, but if you look at the numbers, it's extremely low to draw conclusions. So at least for now, it really doesn't look that the intrauterine infusion CSF will improve the endometrium lining. It's out there. It's a very used as a trial study, but I don't think the data support that at all. Now come to relatively a new kid in the block, which is a platelet-rich plasma. And again, as you know, platelet-rich plasma is a concentrate derived from centrifugation of blood to remove red blood cells. And ACRIs, it have an effect on endometrium regeneration and regulation of immunologic mediators. So this is one of the original studies that looked in 19 patients undergoing IVF between the age of 33 and 45, and they have a history of the endometrium did not respond at all to the normal estrogen replacement therapy. And if you look at those on those patients, once he starts them, we use like platelet infusion, this patient start having endometrium thickness more than 9 millimeter and with a very favorable response and with a 73% pregnancy rate. However, those was a very small group of patients. We talk about 19 patients that were put in this group. And that was one of the earlier report that, maybe using PRP can help improve endometrial thickness or implantation. Now, this became a bigger study. I mean, again, because everything is relative. 83 patient with poor endometrial response to standard hormone replacement therapy, basically below 7 millimeter. And this patient was put in 2 groups, one group that did not receive PRP and the other one that received the PRP, as you can tell. And this is a result of that study, which I really, they said in this patient that has a higher implantation rate. And you look at the study, of course, implantation rate was 21 as a PRP group versus 9.1. But if you really look what we are looking for, the clinical pregnancy rate was no significant difference. So although there's a high implantation rate, the clinical pregnancy rate was not significant. And that always give you a pause to believe in a certain data was really make a difference or not. Again, it's very controversial, it's investigational. The data is not there to support this as of yet. However, this is a meta-analysis, and you can tell using RBR and either repeat implantation failure or thin endometrium. As you can tell, there's two studies that prospectives that looked into this. And again, there are two small studies. One of them, the one that just mentioned, and if you look at the pregnancy rate on to those, yes, it showed a statistically significant implantation rate on pregnancy rate if you put them two together. And this study, in a way, this meta-analysis suggests that using platelet-rich plasma can improve pregnancy. Again, very small trial, very limited trial outcome to draw a conclusion on a bigger picture. Now, endometrium still cell, again, this is again very research-basic kind of treatment, and those basically for patient was most probably like severe Asherman syndrome, like they have the basalis radial of the endometrium was destroyed as a result of DNC or myomectomy, whatever, and the endometrium is very thin and very small. And if you look at those patients, there's 6 patients and had the stem cell with a severe Asherman syndrome, and the endometrium on this patient went from 1 millimeter to 4 to 5 millimeter. So it went to grow thicker, but again, this is a very controversial, very research-based study that showed that endometrial stem cell can improve the endometrium. This is one of my favorite topics, which is endometrial receptivity arrays, the ARA. And I always say that when we look at the endometrium, we look at the endometrial thickness, how thick is the endometrium, how it looks, a trilaminar look, or so on and so forth. But we really don't have any insight about the function of the endometrium, right? So it sounds like when you use endometrial thickness and appearance, it's kind of it's a tool that we have, but also kind of it's descriptive. And it's descriptive, there's a lot of times difference than a functional of the endometrium. So in this one, it have patient that has 13 patients, endometrium was thin, like, like below 6 millimeter. And when they did the ARA, they have 23 non-receptive and 77% receptive, which is basically more or less the same in the patient who have endometrium above 6 millimeter, which is basically like would brings up the question whether a thickness of endometrium alone is an adequate way of measuring the endometrial receptivity or not. I most probably feel more and more that we're going to need to have more of functional tests rather than descriptive ultrasound and thickness on ultrasound to really determine whether endometrial receptive or when it starts the progesterone and so on and so forth. This is a protocol we use mainly here, and I'm going to pass of this. There is a management of thin endometrium in assist reproductive, and this came from the Canadian Fertility Andrology, and I just highlight the important stuff, right? In patients with thin endometrium undergoing embryo transfer, we suggest against the use of mainly the platelet-rich plasma, or the gonadotropin hormone to improve pregnancy rate. That is weak. The same thing you can tell for the CSF. There's a weak data that suggests against user. In patients with endometrium embryo transfer, there's insufficient evidence to recommend the use of Georgr, and it is, they say there's insufficient, the evidence is not sufficient. And then for patients with a history of thin endometrium and ARC treatment undergoing endometrial preparation for transfer, there is insufficient evidence that specific protocols, a natural or anything, will do better. And the last one, in frozen IVF embryo transfer, patients should be counseled that endometrium thickness below 7 millimeter may have a negative impact. And that's what we really keep going back to. Again, I think we're going to have to develop some tests or think more about function of the endometrium rather than how it looks on the ultrasound, at least to figure out which patient will be receptive. I'm going to leave you with this. Thin endometrium is a frequent and a challenge finding occurring patient undergoing ARTA for the embryo transfer. Endometrial thickness during stimulation might predict endometrial response during the FET. Managing possible underlying cause, like there's Asherman's and endometritis, so on and so forth, would help. Prolonged use of estrogen, whether it's oral, transdermal, or vaginal, it definitely is an interesting part to help growing the endometrium thicker. Adjusting the progesterone dose, so progesterone is anti-estrogen, right? So if you have somebody with to start with a thin a thin endometrium. Giving the full dose of progesterone might need to be adjusted, gives them a smaller dose than somebody with 12 or 13 millimeter. That the more progesterone you're going to give, the thinner endometrium going to become. So adjusting the dose of the progesterone might be an interesting part. In vitro receptivity assay will most probably play a role in patients with resistant endometrium. At least give us some understanding if, okay, it's a 7 millimeter or 6 millimeter, or 8 millimeter, and I cannot make it higher than what it is right now. Is it a good idea to do a biopsy to see whether endometrium receptive or not before I put this embryo back in? I believe that might be something we can until we get more. Aspirin might improve pregnancy without increasing endometrial thickness, and I believe that's most probably proven more and more correct. And for sure, we're going to need a large, well-designed randomized trial to evaluate the effectiveness and safety of this intervention, whether using platelet-rich plasma or vaginal Viagra or so on and so forth. I think we're just scratching the surface, and as long as we understand the limitation of the tools that we have, I think most probably eventually we'll find our way to either understand and accept within endometrium, and if it's not, or there's something to do to increase the thickness to improve pregnancy outcome. Again, I'm going to stop here, and I thank you so much for your time, and looking forward to see you all sometime soon.
Thank you, Professor George, for this very nice and comprehensive presentation. I think Professor George with us online. Do you hear me, Professor George? Hello?
Yes, I do. Thanks so much. Yes. Do you hear me?
How are you, my friend?
I'm good. Thank you so much for having me.
Nice
and I'm sorry I went over time.
I miss you so much.
Thank you. The same here. It's my pleasure.
Okay. Professor, I have a question for you, and I don't know if the theater, the audience have any questions, but I will start by my question concerning the issue, the slide that you presented in your presentation in Hari, which was about the Doppler, the blood flow, the endometrial and subendometrial blood flow. I believe in that. Actually, I think I am one of the few persons in the field that I believe that the blood flow, the endometrial and subendometrial, it does affect the implantation rate, and it does affect the endometrial receptivity. But I want to ask you, why the literature, why the papers didn't study this issue, which is very logic, that if the Doppler and pulsatility index is high and the resistance is high, it's very logic that the implantation will be affected and the endometrium will be affected, the receptivity will be affected for sure. Why the literature didn't discuss this issue in a wide range?
Thank you so much for the question. So I think more of the recent literature start to look into this more than the older one. So if you look at the study from Viagra from the University of Cairo, they looked at the pulsatility index. The one that used aspirin also measured pulsatility index. The one that used PRB start. So I totally agree with you 100%. I think the pulsatility index is most probably correlated in a way to the endometrium. Again, we still think about endometrial thickness the most important part, but I think the endometrial function, it is also important. I always say, like, some of us, 150 centimeter tall, some of us 170, 180 centimeter tall, and both are normal, right? So I think the function, it most probably going to be correlated to pulsatility index. If you even look, that's something used also for maternal-fetal medicine people. When they look at the placenta and the pulsatility index, they determine if the baby is compromised or not. So I'm 100% agree with you, and I think more and more we will be more comfortable measuring this pulsatility index, and whether this correlates directly to endometrial thickness or not, or this correlates directly to implantation or not, that with to be seen. But I think going forward, any study to look into a medication or intervention that would improve endometrial thickness would most probably have to also measure pulsatility index in addition to pregnancy outcome.
I have, for myself, I have a small personal experience concerning this issue, and actually, I am asking my patients with after any failure, even single failure, to go and to do Doppler for measuring the blood flow and the pulsatility index in the endometrium and some endometrial blood vessels. And when I found a high pulsatility index, I tried to give them sildenafil and low molecular weight heparin, plus sometimes I'm giving Trental. Afterwards, I repeated the Doppler for these patients. I found marvelous change in these patients actually. And most of these patients got pregnant in the second transfer. I don't know if this is right or wrong. I need your personal experience and opinion.
I think you're into something here. I mean, I really believe most probably aspirin will be most probably helpful in that regard, because it showed the reduced pulsatility index. What I'm listening to now, I'm thinking, so progesterone per se is a smooth muscle relaxant, right? Estrogen per se, it's a stimulant to smooth muscle, right? So I'm wondering whether the pulsatility index after we start this in progesterone, how it's going to look like, right? I think everything you try to do to increase the blood flow to the endometrium makes sense. And again, a lot of stuff we do, it depends on our experience, right? What we saw and what we have experienced before, and what we can do to improve that. But I think anything you do to try to improve the pulsatility index and endometrial thickness, it's most probably going to be positive to improve implantation rate. So I really totally agree with what you're trying to do.
Thank you very much. I don't know if any of the audience have any question for Professor George. Any question concerning the thin endometrium? Yeah, Dr. Skina already has question.
The test for endometrial receptivity array موجود في مصر أو نعمله؟
She's asking about ERA test. Not so present in Egypt, unfortunately, but actually the ERA test, as Professor George may agree with me, that it currently became a little bit part of history. Yeah. The ERA test, there is many papers already attacked ERA tests in the last 2 years, and I think EV themselves now confessed that there was a problem in this test. I don't know if you agree with me that ERA test already has many problems in nowadays.
So here is a problem with any test we do. So if you take the test and apply to general patients with infertility, most probably has a very little justification. If you take the ARA test and you do it on, for example, I'm just it's in all the patient IVF, most probably the data will be all over the place. But I think that the test has a place for a very limited patient that we really don't know whether endometrium or not. Now, it's very difficult to reproduce. In other words, we change from one cycle to another cycle. It has some variation in the gene expression, and all that's understandable. But I still believe it has a little place for the patient that when you have a thin endometrium, and you cannot get any thicker. I think if the test shows a receptive endometrium, I believe it most probably has validity, but not in everybody that would undergo FET. I don't know whether it's available in Egypt or not, and I'm sorry for that. I don't know the answer for that.
Fortunately, it's not available.
I'm sorry.
Okay.
Okay, I'm so sorry. I'm sorry.
Okay, Professor George, it was an honor for us to join us in this meeting, and thank you very much
so much
for your attendance, and thank you for being online with us in this discussion, and see you very soon in our conference in 2023, inshallah. Thank you very much.
Inshallah. Alf salam. Thank you so much, everybody. Thank you.
Thank you very much.